Namaskar to everybody and welcome to this webinar. Sorry for the slight delay. Sometimes there are problems in connecting on Zoom. So today's topic is from toxicology and forensic medicine. Two topics will be covered today. One will be paraquat poisoning, which was requested by one of our viewers, and the other one will be on hanging, right? So these are some topics which are not covered frequently, but they do come to the ICU, and the mortality is extremely high. We should optimize the treatment, of course, after adequate recognition of the complications, and salvage whatever we can, and if possible, give life to these patients. So the speaker today is Dr. Nikhilesh Jain. Sir has been a very active contributor to our webinars. He has conducted many case studies from his ICU. I really thank him for that, and we are obliged and grateful. So today he will be taking the topic, and he is Director of Critical Care Services and Head of the Operational Services in CHL Hospital, Indore, Madhya Pradesh, which is the largest hospital in Madhya Pradesh. So with that, I hand it over to you, Dr. Nikhilesh, sir.
Thank you so much, sir. I'll just put this in slide sharing. This is visible?
Yes, we can see.
Okay.
Go full screen. Where you have to go.
Yeah. So thank you so much, sir, for another opportunity to speak at this forum. Today's topics are atypical, I'll put it that way. One of them is, of course, hanging, and another one is paraquat poisoning. Again, these are topics which are not usually covered in a lot of detail, and our understanding about them is also slightly sketchy because the type of cases that we see are not of those high numbers, so as to prompt a really hard study into this. So as we are already got delayed a little bit, I'll go into the presentation. So whenever we talk in terms of hanging, we talk about understanding the basics. So hanging is a type of strangulation injury. Now, strangulation injuries are a heterogeneous set of traumatic pathologies by a mechanical force which is applied externally to the neck and the surrounding structures. It results in decreased cerebral oxygen delivery either by compression of cervical blood or vessels or by the compression of the airway itself, that is tracheal occlusion. If the patient or should a patient survive the initial injury, care must be taken to evaluate for occult injury. This most of the times refers to or is called as choking, and choking will suggest an internal occlusion or a partial occlusion of the proximal airway. So when we look at etiological conundrums, strangulation always refers to compression of anatomical neck structures leading to asphyxia and neuronal death. It includes hanging injuries, it includes manual strangulation, including garroting and ligature injuries. We need to know certain terms such as what is complete hanging and what is incomplete hanging. And I'm very sure I'm going to take you on a blast back to the past by revisiting your forensics. But complete hanging is defined by full weight of the patient that is suspended by the neck. And incomplete hanging injuries will encompass all injuries in which the patient is supported partially by another object. It could be either the ground below him or her or the furniture. Related terms. Why we talk in terms of, in medical parlance, somebody is called as well hung because in older times, whenever people used to be hanged, they used to have priapism at the end of it. That happened purely because of the vascular changes happening in the body. Then we talk of carotid intimal tears. Along with that, you can even get a complete rupture of the carotid. And there are certain times when sexual gratification is sought by using this. And then you have what they practice in police or what they practice certain times as, restraint mechanisms for mobs or unruly people. That is submission holds or vascular neck restraints. There was a very famous case of a colored individual who actually got strangulated to death sometime back in US. So because that guy was on a submission hold, so this is one of those related terms. When we look at the physiology behind that, where does all the pressure get applied and where all does this pressure effect happen? So external pressure to jugular veins, it will actually prevent the adequate venous return from cerebral circulation, whereas the back pressure would actually prevent the eventual arterial inflow. that can lead to elevated intracranial pressures. You can get loss of consciousness, depressed brainstem functions, and eventually asphyxia and death happens. Then you can get external pressure to carotid arteries, which directly prevents oxygenated blood flow to cerebral vasculature. Coming below, pressure obstruction to larynx, which results in an inability to oxygenate pulmonary vasculature. Then because of this, because there is pressure directed at the carotid bodies bilaterally, you can get cardiac dysrhythmias, which can further lead to anoxic brain injury, watershed infarcts, diffuse cerebral edema, and of course, diffuse axonal injury. So there may be some more findings that you can find here that judicial hangings, when they happen, they can actually result in a very rapid deceleration mechanisms. Classical description comes from hangman's fracture, which involves the C2 pedicles, and it can also lead to hyoid fractures, along with that injury to cricoid and thyroid cartilages. It depends on type of ligature material as well. Certain times, if the deceleration injury is very rapid, you can get a complete cord transaction at that level. These people can have facial and cervical petechiae, ecchymosis, facial plethora, along with subconch hemorrhage. Then you can get vascular trauma, including intimal tears and transaction. So what are the mechanisms of pulmonary edema, which we see in these patients? One is, of course, neurogenic, which is centrally mediated. There's a massive sympathetic discharge in association with the brain injury, and it has got a very poor prognostic implication. Second one would be a post-obstructive type of pulmonary edema, wherein this strangulation will cause marked negative intrapleural pressure. It is generated by forceful inspiratory effort against an extrathoracic obstruction. And when the obstruction is removed, with a rapid onset pulmonary edema, that can actually lead to ARDS. So certain examination points that we are supposed to look at, what you can see in these patients. Of course, what you would get would be ligature marks or abrasions, lacerations, contusions, bruising, edema of the neck. You can get tardive spots of the eyes. Then you can get laryngeal fractures, which can manifest as severe pain even on gentle palpation of the larynx. Then you can have respiratory signs such as cough, stridor, dysphonia, some amount of muffled voice, aphonia, varying levels of respiratory distress. Of course, the patient may be hypoxic, and there may be mental status changes which may be correlatory with the same. How do I evaluate these patients? You can do lab studies, CBC, CMP, coagulation studies, beta HCG studies, toxicology panel, lactic acid, as well as an arterial blood gas level. You need to do CT angiogram of the carotid and vertebral arteries. You need to do non-contrast CT scan of the brain. MRA, that is the MR angiography study of the neck, to know about both global and anoxic brain injury, to know whether there's any ischemic stroke that has happened or whether there's any intracranial hemorrhage. Plain chest radiography to rule out collapse, pneumothorax, or any other lung injuries. And of course, if required, SOS bronchoscopy and upper GI endoscopy may be required. So examination points again. Uh, of course, this is referring to surviving patients. So patient would be in altered mental status, neck pain at rest or with an isometric neck motion. You can get decreased active cervical spine range of motion. You can get a posterior midline cervical spine tenderness. Along with that, there may be some amount of muscle spasm of cervical spine muscles. So management points, you should have very low threshold to obtain diagnostic imaging or testing. Most of these patients would need early intubation and airway management, along with positive this PEEP ventilation or a positive end expiratory pressure ventilation. If the patient is non-intubated and if the patient is coherent enough, this may be feasible, but most of the times we land up with invasive ventilatory support. Then laryngobronchoscopy for suspected tracheal or bronchial injury. Of course, you need to add seizure prophylaxis. And if you are able to see increased cerebral edema, then you have to institute means to decrease the intracranial pressure. There is some role of therapeutic hypothermia in these patients, not very large databases, but yes, they have documented better outcomes. And if you can obviously see some intimal tears or somewhere along those lines wherein vascular complications can be addressed, then that is something that needs to be taken care of. When it comes to airway issues, now most of you have done your ACLS, and for just like a trauma patient, you need to do inline stabilization for these patients. ideal would be to have a video laryngoscopy to aid your intubation, or to do an awake intubation over a flexible intubating endoscope. This is ideal. What about poor prognostic variables? There is mixed evidence on the GCS scores. If your GCS score is more than 3, then it's a mixed evidence. You cannot tell whether this patient may do well or not. But if it is less than 3, it is very sure that they have a very poor prognostic outcome. Anoxic brain injury or cerebral edema on head CT carries a poor prognosis. If the hanging time is prolonged, again, a bad prognosis. If your patient comes to you with a cardiopulmonary arrest, it's a poor prognostic indicator. Coexisted cervical spine injury and hypotension at baseline or at the time of arrival to ICU is again a poor prognostic variable. So when you look at findings which are specific to cervical spine injury, you can get upper or lower extremity paresthesias, pain, weakness, or paralysis. You can actually get a sensory deficit below the level of injury. You can get hyporeflexia and hypo or hypothermia. There may be some amount of diaphragmatic breathing without retractions. These patients may land up in terms of hypotension with bradycardia, which is also referred to sometimes as neurogenic shock. There may be urinary retention or incontinence or decreased rectal tone, which may be coexistent with these patients. Some amount of priapism may happen, and you may find a unilateral ptosis and meiosis in these patients, secondary to a Horner syndrome, which happens secondary to the C-spine injury. So this is all about, hanging. I mean, I couldn't find much more in the literature beyond that. Would you add something to this, sir? If there is anything else?
Think just maybe a couple of points. You have highlighted most of the things. So should we do a MRA also, or just a CT with a CT angio? Because time and all those things, and we are doing different.
It depends on the feasibility. I'm very sure that most of these patients would be intubated. So having the know-how and the facilities to carry an intubated ventilated patient to MRI, personally said, if there's an unstable patient, I would always prefer to do a CT rather than an MR.
Right. Uh, and I think you have highlighted the point that neck vessels have to be seen properly because often they develop injuries which are missed, thrombosis, dissection. That is very important.
Correct, correct.
And the other thing is about cardiac involvement. I think hypoxic injury to the heart also occurs with leading to LV dysfunction as well as because of intense sympathetic discharge. Tachysophos also occur sometimes. We
True,
had
true,
a
true.
patient actually.
That
We
has
got
also been
everything.
documented.
Huh? Yeah.
That has been documented.
Yeah, so we had a patient actually. We did everything. We extubated, and after that, there were cardiac complications. Primary cardiac complications, pulmonary edema, and low EF, and all those things happened. So that is also to be taken into consideration. And mortality is extremely high if the patient comes in cardiac arrest. That is complete hanging, and it's very difficult to revive these patients. That is our experience, and that is what the literature also says. And the other thing
Correct.
is, you have shown hypotension with bradycardia due to neurogenic shock. That is the primary mechanism, but the other mechanism is also described that once you establish the blood flow, blood pressure improves, there can be a reperfusion injury also, leading to
Correct.
hypotension. That has also been described. So, even after you secure the airway and you extubate the patient and all those things, there can be complications. So that is another thing, one has to be vigilant. Our experience with hanging, is not so easy. It's a situation where you have to be very vigilant even after stabilizing the patient and extubating the patient. They go into complications. And like you have mentioned, so many other complications. So one has to do a complete survey neurological examination.
Correct. In
And,
our experience, actually, the complete hanging, most of them do not do well.
absolutely. They come in cardiac arrest, and once they get cardiac arrest, they arrive in cardiac arrest. The literature says the prognosis is very poor, and they don't survive. So the other thing is I think you have mentioned about toxicology screen. That is again very important because often there is concomitant poisoning, whatever form sedation or alcohol intake, because these patients are prone to emotional upheaval. So that is again very important. So I think you covered most of things very nicely, and hanging is definitely something which needs proper care. It's a proper intensive care topic and situation. So thank you for that. Any questions we'll take in the end. Please carry on.
Right. So next topic that I would go on, as discussed in the itinerary itself, we will be covering paraquat poisoning, and there may be some more detail out of that because there are more studies on that. So why should we talk about it? Actually, paraquat is a rapidly acting non-selective herbicide, and it is known as a fatal poison. If the exposure is just in the form of skin exposure or a spray aerosol, it leads to very limited or localized injury. However, accidental or deliberate ingestion has got an extremely high case fatality rate. It is an extremely common method of intentional poisoning, and it is very similar to diquat poisoning. What about toxicology? Both diquat and paraquat are bipyridyl compounds. What really happens is that they undergo repeated redox cycling when they get metabolized. It actually consumes NADPH and eventually leads to MODS. So organs which are most impacted by that are those who have high blood flow, who have high oxygen tension, and who have high energy requirements. In particularly, that include the lungs, heart, kidneys, and liver. It does not readily cross blood-brain barrier, so it does not lead to any altered sensorium per se. What about pharmacokinetics? It's a highly polar and corrosive substance. It is not absorbed in significant amounts across the intact skin or as droplets. However, it is rapidly but incompletely absorbed from gut after ingestion. Maximum tissue levels would be reached about 6 hours after ingestion, and it is actively taken up by cell membrane transporters, which explains that why do you get it in relatively high concentrations in lung, kidney, liver, and muscle tissues. Elimination is primarily by kidneys, and that is the reason why once these patients develop renal failure, the elimination gets reduced further. When we talk in terms of historical points of interest, swallowing more than 30 mils of 20 to 24% paraquat concentrate is usually lethal, and as little as 10 ml can cause significant illness. If the patient already has a history of kidney disease and the age is over 50, it is linked to worse outcomes. Oral and GI symptoms are the most common. You get a painful mouth and pain with swallowing, and along with that, you get a persistent nausea, vomiting, abdominal pain in these patients. Sometimes, when you have significant mucosal exposure in the oral cavity, they can get a generalized burning skin sensation. Involvement of the respiratory system will actually depict severe poisoning, and it is usually fatal. Now, if you have a patient who's having altered sensorium, as I told you before, that this does not cross the blood-brain barrier, it should actually initiate workup for an alternative diagnosis. When we talk in terms of physical findings, you should inspect the mouth and pharynx for necrosis, inflammation, or ulceration. Please monitor the respiratory rate along with pulse oximetry. Unless there is a clear-cut evidence of hypoxia, SpO2 of less than 90%, do not give supplemental oxygen. I'll come to the end of the PPT, wherein I will tell you why we do not do so. Please monitor your heart rate and blood pressures. Most of these patients would be presenting with dyspnea along with lung signs, which suggests that there is already alveolitis happening there. If you get subcutaneous emphysema in these patients, that would mean that this patient has developed a mediastinitis, and that's a very bad prognostic indicator. You can get abdominal pain with diffuse tenderness. If there has been exposure in the form of an aerosol, sometimes you can get corneal ulcerations or a non-specific dermatitis, which may be present in these patients. What about labs? Blood tests should be ideally done at baseline and they should be repeated at every 6 to 12 hours for first 48 hours. Once you're done beyond 48 hours, where how frequently you test depends on the clinical situation, and that would include the presence and severity of vomiting, diarrhea, and kidney injury. Now, do remember that rate of increase in serum creatinine concentrations actually correlates with the survival of these patients. If you get an increase of less than 3 micromole per liter per hour, that is less than 0.034 milligram per deciliter per hour over 5 hours, they are supposed to have a better survival. Whereas if an increase is more than 4.3 micromole per liter per hour, that is more than 0.049 milligram per deciliter per hour over 6 hours, that is associated with mortality. We don't do cystatin C levels very commonly in India, but if you have the facility available, then over a course of 6 hours, if you get an increase in cystatin C levels from baseline of more than 0.0009 milligram per liter per hour, that is again associated with mortality. When we look at our arterial blood gases, most of the times what you get is an alkalemia because of excessive vomiting. Then acidemia happens, which is a combination of respiratory acidosis because of alveolitis and aspiration pneumonitis, and metabolic acidosis, which intervenes because of loose motions, along with acute kidney injury and hypertension. Now, do remember that a lot of people have got a tendency to do venous blood gases. It is a good screening test, can be used for serial monitoring. But remember that for critically ill patients, for hypotensive patients, VBGs may not be of that much use other than telling you about lactates or your central venous oxygen saturations at times. Lactate concentration more than 4.4 millimole per liter or 40 milligram per deciliter or 3.35 millimole per liter respectively actually has been associated with fatal outcomes, and it needs to be measured serially for it to be of relevance or to be used as a prognostic variable. What about chest imaging? What you see commonly are infiltrates, which are as a direct effect of paraquat, which are seen usually bilaterally. You can get aspiration, which is more commonly focal, particularly involving the right lung. You can get diffuse alveolar infiltrates in pneumomediastinum. Then ARDS and reticulointerstitial infiltrates several weeks or much more later than that post poisoning. What you can get is progressive fibrosis. You can actually do serial lung ultrasounds to monitor, these interstitial changes in the lung, which is now a very good modality. When it comes to specific tests, how do you diagnose this? You can do urine paraquat levels. Ideally, in a urine sample, it would come out positive at least 6 hours after ingestion, not before that. And it is actually done by seeing a color change after adding a dithionite solution. If the color changes to blue, it would suggest paraquat. And the darker the color, roughly, the higher is the concentration. When it comes to serum paraquat concentration, it can be done by assessment of nomograms. But these nomograms are actually limited by the fact that the time of exposure is very inaccurate in most of the historical accounts. Then we can do a qualitative serum paraquat testing, wherein we conduct the diethionite test in the plasma of patients who have got a positive urinary test and look for a color change again. Then when we look at nomograms, what are the common nomograms available, So one is a Proudfoot nomogram. Then you have a best cutoff for the severity in paraquat poisoning or SIP score and 50-50 survival prediction. Now this SIP score is actually calculated by multiplying the paraquat concentration in milligram per liter by the time since poisoning. And higher the score, more rapidly is what you would expect these patients to go to mortality. When it comes to management, symptoms and signs of paraquat poisoning will usually manifest within 12 hours. GI decontamination is recommended, but it should be within a specified time frame. Beyond that, maybe you will not be able to achieve anything much. Hemoperfusion or hemodialysis can be done, which is to be followed by continuous hemodiafiltration or repeated hemoperfusion may be beneficial if you can do it, if the patient reaches you within 4 hours of poisoning. Most of the times, what happens is these patients reach us quite late, and we are not able to offer this option to them. When you treat this hypoxia, either by oxygen, NIV on an SOS basis, and subsequently, when it progresses, probably to invasive ventilatory support. You have to use adequate analgesia because these patients may have a lot of abdominal pain. So when it comes to initial resuscitation, unless you've got a confirmed hypoxia, which is labeled as an oxygen saturation of less than 90%, oxygen therapy should not be administered, as it can exacerbate the oxygen-mediated cellular damage, which is actually induced by the redox cycling. When it comes to fluid, 2 to 3 liters of isotonic crystalloid is recommended, unless the guy presents to your hospital more than 24 hours later, and therein you may need actually larger volumes. If your patient is having hypoxia, hypotension, or acidosis, they are all poor prognostic indicators, very high likelihood of mortality. You can go ahead and use activated charcoal or Fuller's earth. I've just mentioned Fuller's earth, preferably within 2 hours of ingestion, but Fuller's earth is no longer available in a big way in India. Activated charcoal is, so you can use that. Gastric lavage and forced emesis are again contraindicated because it gives rise to more lung damage at times. Any role of anti-inflammatory agents or immunosuppression? Dexamethasone 8 milligram IV every 8 hourly for first 72 hours has been used successfully in acute paraquat poisoning, and it can be, if you see any improvement, you can even continue it up to 5 weeks. Then there are some studies which have evaluated cyclophosphamide along with dexamethasone, and that combo has not been validated. Then you get very modest benefits on combining dexamethasone with hemoperfusion. Small studies, not a lot of literature or data to say that this is tangible. When it comes to giving ongoing therapies to the patients, you can use supplemental oxygen, again, purely with hypoxia. You have to monitor lactates and renal functions in these patients. If required, SOS renal replacement therapy and ventilatory support. In certain patients, lung transplantation has been attempted, but it has failed to show benefits uniformly. When it comes to medical management versus palliative care, once systemic toxicity appears, then it is very, very unlikely that whatever you do, it is, going to give you a better outcome. Because there are no antidotes as such, there's nothing that actually works once the poison is fixed and absorbed. Then patients who have clinical and biochemical evidence of severe poisoning should be provided supportive care, but not intensive care. Why? Because you have got nothing to offer to them. It may seem very blanket statement to make, but this is how it is. If your patient has got tachypnea and hypoxia on room air, patient is having refractory hypotension despite adequate fluid resuscitation and clinical or radiographic evidence of mediastinitis, probably we may not be able to offer them much. Then there are associations with mortality, which can include severe acidosis, hypoxemia, and a rapid decline in renal function. All of them portend a higher chance of mortality. And I think this is the last slide. Yes.
Thanks, Dr. Nikhilesh, sir. Can you stop share screen, please?
Yeah.
Let me close it from my side. It's not going.
Okay. So I'll stop share.
Yeah, okay, great. So very nicely covered. Actually, one has to realize the futility of the situation. That is very important. One should not pursue aggressive treatment if the patient is already very bad. And he showed the nomograms don't really apply because we don't do paraquat levels. Definitely for theory that is there, but the sodium thionite test can be done. I think that is available. And there, if you get a light blue color or a dark blue color, that makes the difference. Light blue means toxicity is less severe, and dark blue color means toxicity is severe. So that can kind of give you a pointer whether you should be managing the patient aggressively or not. That is very important. Of course, the onset of renal dysfunction, the onset of hypotension, multi-organ involvement, it causes hepatic injury as well, myocardial injury as well, and even cerebral edema. It can cause multi-organ failure. So that can be very devastating, and one should realize the futility of treatment. And textbooks, like you said, are controversial, are giving controversial this thing treatment. So you showed about steroids, and some books even recommend a bolus regimen with cyclophosphamide and methylprednisolone, and then followed up with dexamethasone. So different regimens are there in different sources of literature. And the other thing in terms of therapy they offer is vitamin C, vitamin E, and NAC, because there is perioxidation as because there is generation of oxygen free radicals. So these are scavengers of free oxygen radicals. So that can also be offered if one pursues therapy. Apart from, there is nothing much. So vitamin C, vitamin E, NAC, intravenous cyclophosphamide, and intravenous methylpred pulses followed by dexamethasone. So that is all we can offer. But it's very important to realize whether the patient is treatable or not. And of course, charcoal hemoperfusion can be done if the patient comes early. And in fact, it should be offered, at least initially, we have to try. And then one has to ventilate also. Most of these patients, they developed ARDS and they go on to get pulmonary fibrosis. And while lung transplant is not really helpful because, if you try to transplant the lung, the paraquat levels they exist for a long time and they cause further damage. So that is one of the reasons why lung transplant is not really helpful, and nothing really works if the patient has consumed too much, and a very small amount, just about 10 to 20 ml, that is 2-3 teaspoons of 20% weight by volume of paraquat is adequate to cause death. It's very toxic. So that is all. Dr. Nikhilesh, anything else you want to add?
No, I think so. So that should be good enough. Actually, I mean, most of the times the patients of paraquat that we see, they come to us quite late. That is unfortunate, but that is how it happens. And probably the only definitive therapy that I would say would be hemoperfusion, but we are not able to offer it to majority of our patients by the time they reach us.
So, as far as hands-on experience is concerned, how do they present generally? You have, I think, decent experiences.
Most of the times these patients are presented with acidosis, deranged LFTs, highly icteric, along with that an acute kidney injury. So they come to me at that point in time. There is about we've seen about 12 in past 3-4 years,
Yeah.
but actually none have survived because they get referred very late.
They come from the periphery, I think, and they refer very late.
True, true, true. They come from periphery.
That is there. That is there for most of the poisoning. You know, if they come early, then we can offer something. But in the devastating poisoning, if they come too late, then it's beyond scope. That is the problem most of the time. So I think there are no more questions. Thanks, Dr. Nikhilesh, sir. A wonderful, lovely presentation, beautiful slides, and I think you have covered extensively. That is all there is to it. And see you again sometime. Thank you so much.
Thank you, sir. Thank you so much for the opportunity.